Welcome everyone to Office Hours. I'm your host, Stuart Newsom, and today we're discussing driving radiology growth through smarter prior authorization. And with me as my guest is Heidi Simpson, who's the operations manager at Advanced Diagnostic Radiology. Now, Heidi brings a really unique perspective because for the last about 27 years before her role here, she was a nuclear medicine technologist, if I can get that out right. Uh, she stepped into operation leadership role and quickly found herself navigating the complexities of revenue cycle, which was quite a transition, I can imagine. We're going to hear more about that. So, how you doing today, Heidi?
I'm doing really well.
Awesome, awesome. So I'm really glad that you're here. I always like it when we have our clients on office hours because it really gives them an opportunity and a voice to really tell their perspective. And yours is a unique one, so I'm really looking forward to diving in.
Oh,
Um,
good. I'm looking forward to this is, your podcast has been one of my favorites. So
oh, thank you. Yes.
I'm honored to be here.
Oh, thank you very much. Awesome, awesome. Well, today we're going to talk about how prior authorization, which is something many organizations see as a necessary administrative burden, can actually become a strategic growth lever for independent radiology centers. So, when handled proactively, prior auth isn't just about getting approvals. It directly impacts speed to schedule, obviously, referral loyalty, patient retention, and ultimately revenue performance. So Heidi's team has leaned into that reality, using prior authorization not just to keep the wheels turning, but to compete more effectively in a hospital-dominated market. So it's almost like a survival skill that they've learned and used.
Mhm.
So as always, we're going to leave time at the end for Q&A. So if you're joining us live, feel free to drop your questions in the Q&A box at the bottom here in Zoom, and we'll get to many of those as we possibly can. And I also welcome comments. If you have any insights or if you have any experiences you want to share, please drop those as well, and we'll try to read those out loud as well. So, all right, Heidi, you ready to dive in?
I am.
Awesome, awesome. So, as I stated earlier, you spent 27 years as a nuclear medicine technologist
Mhm.
before stepping into the role that you have now in operations. So, what was the biggest mindset shift for you moving from clinical care into revenue cycle and operational strategy?
Well, it was taking the one patient that was in front of me, caring for them, doing the best possible exam, getting that to the radiologist. I didn't have to worry about all the steps that happened prior to that. And now that I'm in this role, I have the responsibility of that patient's journey from start to finish in the business aspect. And it's been a huge eye opener as to how complex that can be to get that patient to that particular modality with that technologist.
Right, exactly. There's a lot going on, right?
There's a lot. Yes.
It's it's very complex. And
Yes.
as many of us know in RCM, because I've been doing this 30 years as well, it's any one of those steps can disrupt the next step and just
Correct.
totally implode everything. So I imagine there's just a lot of pressure too, making that transition and likely a lot of trust, because, making that transition, not everyone can do that. So really commend you for, stepping up and tackling it. Some people will run
Thank
for the
you.
hills.
Thank you. Yes, it's been challenged, but it's been a good challenge. And you have to look at it as a whole. And I'm a big component of patient first. And if you put the patient first and you do everything for that patient, for the the good of the patient, regardless of how you're doing anything, it all works out. It all, you want to put the patient puts your trust in this particular setting. So they need to know that you're going to get that prior auth, that you're going to take care of the paperwork, that they're going to get the scan. They're not going to have, any issues with something not wanting to be paid. They're going to get their report and they're moving on to their next thing. If they have something going on, they can move on without worry.
Sure, sure, absolutely. And with that, with those all those behind the scenes type of things that need to go on now that you're in the RCM world, you've talked about, in your explanation there about discovering how much happens behind those scenes.
Hmm.
before a patient is, ever lands on the schedule.
Hmm.
So where do you see the biggest disconnect between clinical teams and billing teams in radiology?
Well, I think they're both working for the same goal. The disconnect sometimes happens when you're not in communication with your billing team and when your clinical team doesn't understand or or think about, hey, what I'm documenting, the order that I'm getting, the auth that I'm getting, everything will eventually hit billing, and all that documentation needs to be correct for billing. And I have tried to, and we're smaller, so we can do this, but I have tried to include our billing team in the role of the clinical team as well. I've tried to, if we have a staff meeting, I sometimes will have our billing team, even if one person on the team could call in, and
Mhm.
they give us their headaches and their issues. Hey guys, this hasn't been correct, or this you're getting this off, but that CPT code is not correct. So that we stay in constant communication with each other. That way, we're trying to catch everything on the clinical side before it hits billing side, so that any type of CPT issues or prior auth issues, that is kind of nipped in the bud before the patient is even here.
Yeah, yeah, and that's so
So
important,
yeah,
and I think
keeping
a lot of
everyone
times,
on the same page has been huge.
yeah,
Yeah,
and that's key because clinical teams and billing teams have such different perspectives.
they do.
And I've
They
often
do.
stated that, clinical teams, especially when they document, they're documenting for another clinician. So when they
Mhm.
write things down, and nobody really writes things down anymore, I hope, but but they're
Mhm.
putting in the documentation. They may be using certain verbiage, certain
Yes,
notations that they know another clinician is going to understand. You don't have to
right,
explain it out.
right.
And billing teams, I've learned, I mean, years ago, it was, someone was doing the coding, someone was doing the billing.
Hmm.
Now you have to understand those clinical notations and get that
Yes,
perspective in order
yes.
to code it right and bill it
Hmm.
right. Because then I'll often say, coding is the language that payers use to understand what happened at the encounter, what happened with the exam, what
Hmm.
happened with that visit. And if it's not interpreted correctly, then you know what's going to happen. You're just not going to
Right.
get the revenue you're expecting. It may
Exactly.
not end up in a denial, but it could be down coded, could be coded with for less reimbursement. So it's just very important that those two teams align. And it
Yes.
really just sounds like you've done a great job in making sure they align because that's the first step, is
That
communicate.
is the first step. Yep. And if they have a question, if our nurse practitioner did a procedure and they're not sure, like, well, what things are, and they're trying to code and work on billing for that particular procedure, get them in touch with each other and say, hey, talk to her for a second. The next time that you have it, this show up, you're going to know, and be open with us. Like today, we just had a little short meeting about maybe some insurances that we're no longer working with, or that things are going on. And our girls in clinical side need to know that as well, so that we know who we can, for lack of better words, what they're thinking and what they're seeing and what we're doing on our end. And I know when I first started, that was a big disconnect. And just having those teams meet up together has been great. Takes time. It takes time out of
Yeah.
everybody's day to try to do that, but it's worth it in the end.
Right. Exactly. Exactly. Everyone, like you said, being on the same page. That's for sure.
Yes. Yes.
So when we were talking and getting set up for this episode, you stated that, you operate as one of the only freestanding radiology centers in your region. Um,
Mm-hmm.
and it's definitely a competitive market where
Yep.
you compete directly with large hospital systems,
Mm-hmm.
which can sound intimidating. So if you could kind of walk through kind of describing, your organization a little bit and what pressures does that create operationally when you're facing, the Goliath out there?
Mm-hmm. It's difficult in the fact that the health systems in our area obviously want their clientele and the patients to come there. The
Mhm.
patients have a choice. So we have to be on top of our game so that they want to come here. It's the patient experience. And the issues that we've had is, the patients have been here for multiple exams. They go to the health system to see their provider, and the provider says, well, you really need to have this done here. And we have to give credit to our patients because they will sometimes fight to say, hey, we want to go to advanced diagnostic radiology. And we're I call us small but mighty. We do everything and all the procedures, a lot of interventional radiology, thanks to one of our radiologists. And we'll probably touch on this in a minute, but we have decided to help get the prior, or we do the prior auths for several of our providers, just so that
Mhm.
we can keep that clientele and take burdens off of other people. We have to be very strategic. We have to plan. We have to be aggressive in certain ways just to be able to get that the patients in, and revenue obviously is come down a good bit. Our
Mhm.
bottom line is different because of how small we are and because we're an outpatient center. We're not a hospital. We can't use a lot of that leverage. So it's
Mhm.
been a challenge, but a challenge that you can make it work. And this we've been in business now for over 20 years, so it can work. You just have to find what works best for you, but it can be very successful.
Right, right. And that's something that's being very creative because I know margins are very low.
Very.
And you have things like, MIPS and other factors that weigh in, and you're like, okay, how are we going to make up for this? So
Right.
being creative in that environment is really a testament to where, okay, and you've turned it to where how do you serve your providers? How do you serve your patients
Mhm.
better
Exactly.
instead of
And
going,
being,
oh, yeah, exactly.
yeah, yes, open communication with them as well, just like with my billing team, calling my providers. Hey, how can I help you guys? What do you need? What is working for you? What isn't? Is there anything else that you need from us? Even doing some visits with them, taking them a
Mhm.
lunch and saying, hey, what can we help you with? You have to be willing to put yourself out there to make something like this work.
Right, exactly. And in many ways, you're much more agile, because I
Hmm.
kind of picture it as, a small ship that can turn,
Yes,
with just the move of a rudder, but a large ship takes a long time to
correct.
turn and react.
Yes.
All right. So,
Yes. When you're private too, that helps. We don't have the politics, and we can move patients through a little bit a little quicker. And yeah.
yeah, and that kind of leads to like the next question. Many organizations see prior authorization as a burden.
Hmm.
And it's typically up to the referring provider to do that prior auth, if they indeed do it, and then they don't follow up on it because, hey, it's a checklist. They're moving to the next patient, even though this is still their
Hmm.
patient. They're relying on information and the service you're providing to help them diagnose the patient and other aspects, what treatment plans are doing. But they're still kind of moved on, so it's
Hmm.
following up with that prior auth.
Hmm.
But you've actually turned it into a competitive differentiator, by
Hmm.
handling the authorizations, like you said earlier, for your referring providers. I'm sure they just love that. So
They
tell us a
do.
little bit more about how that strategy evolved. The idea that first came up, and then the concept, and really getting everyone to buy into that.
Well, we just speaking to providers, we realized that it was a huge burden on their staff. It was a burden also to the patients because they would call us and they'd say, hey, I wanted to see if my physician has scheduled my appointment for me yet. No, they're waiting on your auth. And it was multiple phone calls for the patient to their provider's office to us to see if it was done, phone calls from us to the provider to see if the auth was done. And we took a burden that we were seeing and we thought, let's make this opportunity. This is something that we could grow from because we can say, hey, send us your order, send us your clinicals. We'll get the auth. Once the auth is achieved, we'll call the patient, get them scheduled. The providers obviously are happier because it takes a lot of burden off of them and their staff. We've utilized Infinex to help us with that and that's been wonderful because Infinex meets you where you are, helps whether they need to help. If we need a same day, if we need a stat, it's like a tool in our toolbox for our staff that's working on us. And also, it takes the patients are happier because they know when they leave the provider's office, advanced diagnostic radiology isn't just going to get me scheduled for my appointment, but they're also going to get our the
Hmm.
auth for me. And it's going to be seamless for them as well as the providers. And the providers have put a ton of trust in us for doing that. They trust us. And it starts too with, we can even see if an order comes in incorrectly. We had issues in the past where we were authing an order that wasn't even, the office, sorry, was authing an order that wasn't even correct. Then by the time that gets to the patient level, they're getting scheduled for the scan. They may show up for it, and oh, it wasn't the correct order. So
Hmm.
we're all those delays we're getting rid of by doing it ourselves. And it takes
Yeah.
some work, and it takes a good thought process. It takes a team like Infinex to help us, but that's been a huge, huge part of our success here at ADR. A huge, huge part, and it's worked
Nice.
out quite well. And you have to just not, my staff, we just don't look at it as a burden to us. We look at it as, I tell them, we're not selling a physical product. Our product is the patient experience, the patient getting scheduled for their exam quickly, the auth being obtained, everything happening. And that's how you get patient retention, at least for
Mhm.
us.
Mhm. Yeah, I mean, and understanding that you're a smaller organization, you're
Mm-hmm.
having to scrap and be scrappy, so to speak,
Mm-hmm.
I guess,
Mm-hmm.
to
Yes.
survive. And
Yes.
I am going to throw in, a question here that we've kind of talked about, but that leads into the next question, kind of speaking a little bit more to Infinix and what Infinix is doing for you. But there is this belief that hiring more staff solves everything. It's like, hey, we're just going to throw more bodies at this you
No.
know,
Mm-mm.
even, and we all know radiology is pretty complex, but,
Yes.
but you got all that onboarding, right?
Mm-hmm.
What makes onboarding and training in radiology particularly challenging? Especially when there's probably some turnover rate, maybe there's a talent shortage. I, I'm giving examples, but I'll let you speak to it.
Yes. Well, radiology is a special breed. Anybody that's worked in it and in it knows that. And it's its own
Mhm.
little ecosystem. So hiring someone who has no radiology experience, unfortunately, the onboarding process is long in order for them to get up to speed quickly. There's so many things that they need to know so that we don't get denial, so that we don't have issues with the wrong test, the wrong study. They have to know risk system, PAC systems. Our staff here helps some of the radiologists with some of the things with the dictation system. And
Mhm.
radiology scheduling is a beast of its own, and they need to know preps. And there's a lot of stuff that you can put into your system. We have a new risk system now that is helping with that, but they
Mhm.
have to understand what they're doing. And we take extra steps here when my staff, when we onboard a new staff member, my staff, like our MRI technologists, will take them down and show them this is what an MRI coil looks like when you're scheduling a knee. This is why weight matters. They to get
Mhm.
the whole picture. And I
Mhm.
think it's a special great the administrative assistants in the radiology world are like gold, really, because it starts with them. It starts with them, and it helps make everything flow from start to finish. So whether they're working on prior auths, whether they're answering the phones, whether they're scheduling, whether they're helping our radiologists, it takes a good while. I would say a good year to say that somebody is really trained and effective, and we can move them around to different places if need be. So you want to
Mhm.
retain those people. I try to meet my staff where they're at, put them where their strengths are, and, for lack of a better term, keep them once we get them
Right.
trained. You want them to
Right.
stay. Yeah,
Exactly.
because they're a huge, valuable asset to our practice.
Right. So you're serving the patients, you're serving the
Hmm.
referring providers, and you're also
Hmm.
serving your own staff. And that's
Yeah.
just probably one of the most important, right there
Yes.
as well.
Yes.
So, but still, there's room for you. You mentioned implementing new systems, and also you mentioned working with Infinix and the work that we do
Mhm.
for you, and also AI enabled tools. So what have you learned about the reality of automation versus the expectation that technology immediately reduces headcount?
Mhm. Well, I think everyone assumed AI is coming for my job. I'm going to lose my job. We're going to flip a switch and AI is going to take over and you may not need me anymore. So there was a lot of hesitation to come into this. And we have learned very quickly, especially I feel in healthcare, AI is not taking anyone's job. AI is working right beside us as a team member. You have to train AI. We are training AI and telling AI, this is what we need. This is what our world here in radiology needs. And AI is learning from us, and AI is working basically right alongside of us as a team member to make our lives more efficient. Um, it takes a while to. A lot of people I think thought, "Oh my goodness, this is going to run right off the bat the first 48 hours." And we're learning that it is a transition. It's taking time to teach AI what we need it to do, what we need it to help us with, and we're seeing success, but it's not overnight. It's not overnight. And I think we're talking, you know, 5 or 6 years or even longer before AI in the world of radiology is really up to where it would even eliminate a job.
Hmm.
So I think a lot of people were nervous about that. And we've learned that, hey, it can be a team member. Don't be afraid of it. Utilize it. It's going to help. It's going to make our systems faster. It's going to make take a lot of the little work, the stuff that a lot of maybe staff members aren't crazy about doing. It takes that away, and we're using it as a team member working right beside us. And I think if other institutions and other businesses that see it as that, it's not so scary. It's more of a team player.
Nice, nice. And so it's a lot of change. There's a lot of things to consider. I think, I would imagine you were overwhelmed at one point.
Extremely.
And so, but you've been through the school of hard knocks, I like to call it, and maybe
Mhm.
learned, from
Yeah.
experience. So taking all that advice, taking all that information, if another operations leader at an independent imaging center asked you, where do I start? What would you tell them?
Well, you need to come into it and look at your team and your operation as a whole. One thing that I had to learn is I'm very type A, and I thought I could change everything overnight. You can't. I've spoken on this before, meeting your staff, listen to your staff, meeting them where they are and putting them where their strengths are. And also, it's huge, I think, to talk to your providers. Where are they? What do they need from you? And just slowly change things little by little and make it your own. And I come back to, I'm a huge component of patient first, and we're doing this for the patient. Everything that we do in radiology is for the patient, whether that be prior auth, whether that be getting their exam done, getting the best quality exam, getting them in quickly. It all comes back to that. And I tell my team, if we are doing this for the purpose of the patient first, everything else is going to fall in line. And I think healthcare, you say in the podcast all the time that healthcare, it is broken, but we just have to stay in the mindset of, why are we all here? Why are we all doing this? And I
Right,
just I reiterate that to my staff constantly. And I think listening to providers, like I said, listening to your staff members and realizing that you are not going to change this overnight, but slowly you're going to build it to where it needs to be. If you just have a listening ear and you're willing to put in the work and take the time and still communicate.
right,
Communication is key.
right, exactly. Because I got news for you. It's probably going to stay broken for a long
A
time.
long time.
And
Yeah.
but there's always something to evolve and to correct, course correct. And
Yep.
technology certainly helps, but it's just good old fashioned
Good old
relationships,
fashioned.
kind of everything that you've spoken about, today.
Yeah.
So,
Yeah.
um, so with that, I mean, that's kind of all the questions I have. We are going to switch to some audience questions, and
Okay.
see if there's any that we have available here. There is one that I'd like to run by you that was from the audience, but it says when you think about growth, what outcomes matter most to you? Is it scheduling speed, referral volume, staff capacity, financial performance? What's telling you it's working?
Well, I think all of those are important, and we obviously look at all of those and we measure all of those. But I think how I determine growth is patient volume. Are the patients coming back to us? Are the providers still continuing to refer to us? I mean, obviously, we bounce back to all those numbers. We have staff meetings. We look at our numbers. We look at everything that's happening. But you're growing if your numbers are growing, if your patient volume is going up, and that's the heart of it all.
Right, right. That's awesome. Yeah. So the outcomes, it'll
Mm-hmm.
be evident by its fruit, so to speak,
Mm-hmm.
right? You'll
Mm-hmm.
see that it's
Yes.
working.
Yes.
Um, so here's one more,
Okay.
and it's in the advice category, it looks like. So, what advice would you give other leaders who feel pressure to modernize but are still managing paper and manual steps?
Yeah, that's a good one. That's also not going to happen overnight. I was super concerned and worried about this, also with AI. And I listened, it was your podcast, and I think I've told you this was your podcast where I heard somebody say, well, we still have paper. And I'm like, oh, thank goodness. They still have paper too. You're not going to eliminate it all. It has to go in phases. It's a learning curve, not only for your staff, but also for your patients. We
Hmm.
went to checking in with iPads. We have Abidox as our risk system now, so the patients do a lot of their forms on an iPad. And for some older population, that's not easy. And there are days when my staff wants to say, let's forget the iPads, let's go completely back to the paper forms. So you have to have a balance there. You can't let that happen because you do need to move forward, but you also need to understand that you're not going to be 100% paperless right off the bat. So that was a huge concern of mine. And it was this podcast that made me feel a little bit better because someone else said, you know what, we still have paper. And we do. We've definitely cut down a tremendous amount, but it's nothing like it was. We still have a few things. And I know that in soon in the future, we're working towards being completely paperless. But yet again, in the world of radiology, that's also difficult.
Yeah, it sure is. And I don't know
Yeah.
if it'll ever reach that. I know
Status of, mhm,
there's a lot in the digital age. There's a lot of technology that's coming around, and you're right. I mean, everyone's doing things on their phones, and there's
mhm,
apps and there's iPads, but
right.
still, paper appears.
Yes,
Paper's
it does.
everywhere.
Yes,
Uh,
it
and
does.
and you know who else is a big culprit in payers? It's just the smaller payers will
Hmm.
always they deal in
Yes,
paper as well. Um,
yes,
so
yes.
it's never going away.
And
So
if you have a glitch, which we have, let's say your risk system glitches on you and something
mhm.
happens, you've got to have a pen and paper. So
That's
save
right.
your forms, save all your
Yeah.
forms, have them ready to go. Because if something happens, you're still
Well,
gonna do it on paper.
yeah, you bring up a very good point there because you always got to have a contingency plan. What is your fail
Yes,
safe? What is your backup? I mean, kind of
yes.
it, it's an interesting analogy, but I was in artillery in the Marine Corps, and we had this computer system that would calculate, where the rounds were supposed to land. Well, suddenly the computer would go, as in a drill, the computer would go out. So we had to figure out how
Mm-hmm.
to do it manually. So we had
Mm-hmm.
everything going in side by side. So it's kind of the same thing, So
Yep.
these systems will go down. There may be
Yep.
cybersecurity out there is running rapid. So it's definitely. I just wanted that was the best example that came to my mind when you were
Yes.
talking about that.
Yes.
So
Yes. You
yeah, you
have to
got to have
be
that.
able to pivot and pivot
Yep,
quickly.
yep, yep.
Mm-hmm.
Exactly. Well, I think that's all that we have from the audience. That's also all that I have. Heidi, I really appreciate you coming on. Thank you so
Thank
much.
you.
This was a great conversation. You'll have to come on again for
Oh,
sure.
I would love to. I would
Okay.
love to. I
Awesome.
appreciate you. It was an honor to be included in this podcast. I hope I brought, value and to be able to help someone else who's in this situation. And I appreciate it. I
Yeah,
appreciate the
absolutely.
opportunity.
Absolutely. And I appreciate everyone else joining us for this episode as well. Can always listen to it. We repurpose this for our podcast as well as we have two other episodes per week that go out on our podcast, as Heidi mentioned. It's Revenue Cycle Optimized, so you can go out there and catch us there. You can also go to our website at infinix.com. We have a lot of case studies, we have articles, blogs, and also solutions that you can look at for insights on how to improve your RCM. So until next time, we'll see you at the next office hours.